All right, so we're going to get started. Hi, everyone. Welcome to this week's installment of the National Fellow Online Lecture Series. My name is Samantha Mazzeo, and I'll be your moderator for this evening. This is a lecture series sponsored by our Fellows Online Education Subcommittee through our Education Committee of AMSSM. We're excited to welcome Dr. Ben Oshlag this evening to talk about etiologies and management of the collapsed athlete. But before we begin the lecture, some housekeeping items and announcements. The goals of this lecture series is to assist the fellows CAQ exam prep and to be an adjunct to your home program's educational content. We hope to provide the fellows with direct access to educational experiences with AMSSM members and invited guest experts. In order to optimize this educational experience, we invite you to share ideas on topics and speaker suggestions so that we can represent all topics, regions, and specialties. To do this, you can go to amsssm.org website and use the dedicated form as seen here, or you can scan the QR code here, which will take you directly to the form. As a reminder, the goal of this lecture series is to provide the CAQ prep for fellows, so keep this in mind when providing feedback. We would also like to promote the AMSSM Library of Sports Ultrasound Pathology. This is a collection of sports ultrasound pathologies published on the AMSSM website. Any attending or trainee can submit cases. All pathologies are welcome, and these publications can be added to your CV. You could scan the QR code here or go to the website listed here to explore cases and learn more. You can also email Dr. Schwanz or Dr. Waldrop with any questions. Before we get into our topic for tonight, I want to remind everyone of next week's lecture. We'll be joined by Dr. Jeremiah Ray for a lecture on peripheral nerve blocks, and the session will be moderated by Dr. Sarah Razor. Some rules for this evening. We ask that you mute your device's microphone and turn off your video. You may submit questions at any time through the chat function. Feel free to include your name and program if you wish, but not required. At the end of the lecture, I will moderate the questions submitted through the chat. And don't forget to share your feedback with us at the end of the lecture. So I invite you all to please join me in welcoming Dr. Ben Oshlag. Dr. Oshlag is a dual-boarded sports medicine and emergency medicine physician currently working full-time in the emergency department at White Plains Hospital in New York. He is the co-chair of the Emergency Medicine Subcommittee for the AMSSM Education Committee and the founder and co-chair of the annual AMSSM conference. He previously served as a team physician for Fordham University and is currently an event physician for the NBA. He graduated from the University of Pennsylvania School of Medicine before completing his residency at Hahnemann University Hospital and fellowship at Duke University. He has special interest in sideline emergency care and in sudden cardiac arrest in athletes. Dr. Oshlag, please feel free to share your slides and take it away.
All right, thank you, Sam. All right. So as Sam mentioned, my talk tonight is on etiologies and management of the collapsed athlete. I have no disclosures. The goals for tonight are to review the initial evaluation and management of the collapsed athlete, discuss causes and treatments for cardiac arrest in athletes, emphasize key factors in improving the outcome in cardiac arrest resuscitation, and then review other causes of down and unresponsive athletes and the relevant treatment. One thing I want to talk about real quick is sideline emergency preparedness. So to address all the things that we're talking about today, we have to be prepared and to know what we're going to do on the sideline, in the field, at the race, wherever you are, in order to provide care for that collapsed athlete. Your role is not the same as it is in the office, in the training room, or even in the emergency department. So take your mindset and you have to shift it to what you're doing on the sideline. You're not always providing definitive care and you don't have the same resources available. Your goals are really assessment, stabilization. Maybe you diagnose what's going on, maybe you don't. As long as you know what to do, you don't always have to know what exactly is going on. And then disposition. Is this person going back on the field? Are they going home? Are they going to the hospital? What are you going to do with this person? And then how do we best prepare to provide that appropriate care? What do we need to have with us? What do we need to know? And you can do a whole talk on what goes into your sideline bag, sort of beyond what we're doing today. But think about those things and be prepared to answer those questions. So what are we treating? I'm going to spend a lot of time tonight talking about everything about the collapsed athlete, but a lot of time on cardiac arrest. But also know that when you're on the sideline, you have to be prepared to deal with head and neck trauma, chest and abdominal trauma, extremity trauma, bleeding, environmental factors, and then a whole host of medical issues that may come up. And the most important thing you can do is to plan, prepare, and then practice what you're going to do in these situations. So the first thing I'm going to talk about is sudden cardiac arrest. And this is going to be a big chunk of the talk tonight. We're going to start with a case. It's a real case, and I'm going to show a video in a second. The video is a little bit hard to watch. I watched it at this point probably hundreds of times, and it doesn't get easier. It's a professional basketball player with no known medical history in the final minute of a game. And you're going to see a collapse, and you're going to see the response to the collapse. And what I want you to keep in mind is what should have been the appropriate care, what happened, and what we could do. I don't show this video to criticize anyone or to blame or point fingers, but really to take a look critically and see, what can we do to make sure that we do a good job in these situations. So this is from 2018. If you look at the bottom left part of your screen in a second, you're going to see someone go down. You don't really see it from this angle, but you can see right there, you see the player down. Play stops appropriately, and you see medical providers running out. And look from the right, you see someone running in, and you can see in their hand they have an AED. That's a good thing to do. It's there, it's next to him, they're opening it. He's laying down prone. And this is where it gets hard to watch because you can watch for several minutes as he lays prone and there's no assessment, there's no recognition that he's in cardiac arrest. If you listen to the announcers, they're concerned, mate, did he run into someone? Was there trauma? Is this a spinal issue? That sort of thing. And that I think they may have been a little bit of focus on that. It's hard to know. But if you look, there's a video from another angle. There was no trauma here. He just collapses. And again, you watch the 80s there. It's open. It doesn't get used. And here it's unclear from watching this. Someone calls for EMS. I don't know if there's a hand signal or someone shouted over to them, but you'll see them come in from the top left. In the meantime, we're getting a towel. And again, this is hard to watch, especially knowing the outcome. And so you see EMS coming in. Hard to say if there's a sense of urgency there or not, but it's certainly hard to say that there is one. And they do, you see now there's a second cardiac monitor there. And this is still within a couple of minutes of the collapse. So still pretty early on. We've got people there, but we're not doing the right things.
He had a collision of some sort. We did not see it. And not speculated at all. So they're bringing out
and this is kind of where the video cuts off. We don't really have TV feed of the rest of this, but this is Zeke Upshaw, and he was playing in the G League in 2018. And again, from the video, the AED shows up 15 seconds after his collapse or less. It's left on the floor unused. It was over 4 minutes before he was put on a monitor, 7 minutes before CPR was started, and they got RASC, return to spontaneous circulation, at 40 minutes. 40 minutes of downtime is essentially not survivable. He was prone and there was no attempt to roll him over or assess the ABCs. So there's no determination of a cardiac arrhythmia, of a pulse, that he was in arrest. There's no recognition there. So there's no early CPR. You're not going to do CPR if you don't recognize an arrest. There's no defibrillation. He was on life support for 2 days and then removed and did ultimately die from this. And the quote, from the settlement that ultimately happened was, despite this undeniably dire situation, no life-saving measures were attempted, no CPR was initiated, and no defibrillator was used. So what should we have done instead? How can we learn from this? So ABCs, and this is drilled into every emergency medicine physician through training and a lot of other specialties too. It's really ABCs, really CAB. They sort of changed the language around that because ABC is a convenient acronym, but circulation really comes first. And when you have a collapsed athlete, it's a cardiac arrest until proven otherwise. And it may be easy to prove that it's not a cardiac arrest. If they're on the ground and they're just talking to you, they probably have a pulse. But you need to think about that, and it needs to be your first assessment. So your approach, scene safety, and we'll talk about a little bit, just to make sure that you're not going to become a patient. Activate EMS, because as soon as you know you have someone collapsed in a dire situation, you're going to need to move them at some point. You're going to do some sort of assessment before you move them, but you want to get that motion in process because it's not immediate. And then early CPR, early defibrillation, that's what's going to save lives. And then rapidly transporting them to the definitive care once you have some sort of stabilization, or at least as much as you can get. So scene safety, again, the scene has to be safe to render aid. You don't want to become a patient. So check your surroundings. Was there a cause of collapse that was external that's still a danger? Are there teammates, bystanders, crowds, things like that that are going to be an issue? Are you out on a race and there are vehicles driving by, on an open road course on a triathlon or something like that? Just make sure that you're safe. Is there lightning? Is it hot, cold? Are there animals? And PPE, I think, is much more prevalent post-COVID, but making sure that you have the appropriate protection for yourself. And then your initial evaluation. This is BLS. This is basic. You go and you take a first aid course, and this should get drilled into your head. You assess for response. Hey, are you okay? If you get a response, great. If you don't, you're activating EMS and then you're checking. This is the look, listen, and feel. We all learn this. Simultaneously for 5 to 10 seconds. Check for pulses, check for breathing. Agonal breathing is not sufficient. If they are gasping occasionally, that is not a sign of life. That is a sign of impending badness. If you have a second responder, you send them to go get an AED, and then you start your CPR. If you're not sure, do compressions. You're probably not going to cause harm by doing compressions. If the patient tells you to stop, then you stop. But otherwise, it's more likely to be beneficial. When the AED gets back, you put the pads on. You pause CPR for rhythm analysis and shock. The AED will tell you what to do. They're very good. They announce, but you really want to limit the time off the chest, and then hop right back on either after a shock is given or if it says no shock advised, then you jump back on. And you're going to switch out doing compressions every couple of minutes because it is very tiring. So why do we care? Well, this is your survival curve. And it's not really a curve, it's the ski slope that is way too steep for me to ever go down. Your survival rates during a VFib cardiac arrest decrease 7 to 10% for every minute that you delay defibrillation. So if you get defibrillated, and again, that AED was by his side within 15 seconds. If you get defibrillated, then your chances of survival are 85% or up, 90%. Very, very good. By 10 minutes, it's essentially zero, and that drops off very steeply. So the faster you can get that defibrillator on and use it, the better the patient's chances are of doing well. One of the ways we know this, I love this study. They went to Vegas, because you have more cameras and more security guards there than anywhere else. And they said, if you see someone go down, here's an AED. Take it with you to the initial evaluation. Don't go assess and then call EMS or assess and come back. Just take it with you so that you can defibrillate them as fast as possible. Because we're watching everywhere and we can see, and they got very good data, right? In your casino, there's always someone watching. The survival rate for people who got defibrillated within 3 minutes was 74%. And then it dropped to 49% for people who got it after 3 minutes, but it's still pretty good. How good is it? Survival rate for out-of-hospital cardiac arrest in general is 10%. In hospital, it's 20 to 25%. And that comes with a whole bucket of caveats. People who arrest in the hospital arrest for very different reasons than people who arrest outside the hospital. They're already sick, so that survival rate is going to be lower. But 74% is a ridiculously high survival rate. So that just shows if you are prepared, if you can act quickly, you can really, really help a lot of people. So the timeline of cardiac fibrillation, why is it so important for it to be done so quickly? The first 5 minutes, your cardiac muscle cells still have energy stores. They've been getting oxygenated blood. They're able to do all the metabolic things that they normally do, but they're running through that oxygen pretty quickly. But if you can defibrillate them quickly before they start to die off, you can get them into an organized rhythm again. The heart can beat, and you can perfuse the coronary artery. So, right, the heart has to perfuse itself. That sends blood through the coronary arteries, and that keeps the heart alive. So our goal here is to keep the heart alive. After 5 minutes, between 5 to 10 minutes, you're in this hemodynamic phase where you're starting to deplete those cardiac energy stores, and it gets less and less likely that those cells are going to respond when you defibrillate them. But if you can do compressions, if you can keep circulating blood into the coronary arteries and keep those cardiac cells alive for longer, you're going to improve survival. After 10 to 15 minutes of no circulation, of no oxygenation of the cardiac cells, there's really not much that's going to impact survival. Your heart cells are starting to die off, and that heart is just not going to do well. So Early defibrillation, early CPR save lives. This is how you impact survival. Bystander CPR, when no AED is available, has been shown to improve survival. So just doing CPR and just perfusing the coronary arteries does enough to buy you time to get to better care, whether that's an AED, whether it's EMS showing up and doing all the things that they do. Again, early defibrillation, early CPR save lives. It also has to be effective CPR. So quality chest compressions are crucial. You have to be able to compress enough to squeeze the blood out of the heart, and then you have to release and allow for enough recoil for the heart to refill in between compressions. And you want to compress again 100 to 120 compressions per minute. And there are all sorts of songs you can go through in your head. Optimistically staying alive. People who are more pessimistic sometimes go another one bites the dust. They're probably more topical ones now, more modern music, but I don't know those because I'm old. But when you do good chest compressions, they are hard. You're going to cause injury. That is okay. You might cause a sternal fracture, rib fractures, hemopneumothorax, other traumatic injuries, but an injured alive patient is much better than a pristine dead body. So do effective compressions, and these compressions are going to be tiring. You're not going to be able to do them for more than 2 or 3 minutes. You want to switch every 2 minutes before you're exhausted so that your compressions are still effective. And if you get tired sooner, switch sooner. Don't try to be the hero. Have other people there. Typically, in the kinds of situations that we're dealing with, we're not the only person there. If you are, then go as long as you can. But switching is good. Also, minimize the hands off the chest. If you have a pause of greater than 10 seconds, you're basically starting from scratch. The heart is empty and you have to refill it. And those first few compressions don't do anything in terms of perfusing anything. You're basically just repriming the heart. So if you can minimize the hands-off time, you can increase survival by up to 300% in out-of-hospital cardiac arrests. So excessive pauses for pulse checks, ventilations, intubation, IV access, other interruptions can cause harm. You really want to just do as much CPR as you possibly can. If you don't have an AED and you don't have airway supplies, you can do compression-only CPR. You don't have to worry about the breathing at this point. You have several minutes of oxygenated blood that you can circulate, and even poorly oxygenated blood circulating is better than none. If you look at the data, 13% of cardiac arrest victims survive with compression-only CPR compared to 7.8% with standard. That's because of the pauses. You're taking breaks to give breaths. You're taking breaks to fiddle with your airway equipment, things like that. If you have a non-rebreather or nasal cannula, you can throw it on their face and just crank it up as far as it'll go, and you get a lot of apneic oxygenation that way. You're just blowing oxygenated air into their lungs. That's enough. Don't worry about stopping. Just do compressions. And have a plan. So being prepared improves survival. You should have an emergency action plan to know what you're going to do in a situation like this. These thankfully don't happen often. I actually have never had a cardiac arrest at an event or a game that I've covered. But I would know, you want to know what to do if that's going to happen. You want to know your communication. How are you going to activate EMS? How are you going to get your team together? Who's going to be leading? That sort of thing. Where's your equipment? Is your AED behind a bookshelf that hasn't been moved in years? That's not good. Make sure it's not. Make sure that you know what level of responders you have. Do you have basic EMTs? Do you have paramedics on the sideline? Do you just have an athletic trainer? Do you have some parents who may or may not have some level of training? And then how are you going to transport? Make sure that your ambulance is not blocked by the team bus, things like that. And then make sure your equipment is up to date, your AED, the battery life is good. And then you want to plan and review this and you want to practice it. At least yearly, preferably more often than that, because like any skill, this is going to fade if you don't use it. So you need to practice, you need to run through simulations just so that you're prepared. And then pregame meetings are important also, just to go over all of this stuff right before an event starts or right before a game starts. And one of the things that happens during those pregame meetings and was an issue with Zeke Upshaw is that it turns out he had had a syncopal episode several months before and had been diagnosed with hypertrophic cardiomyopathy. I don't know if the people there knew that or not, but knowing that certainly changes how you approach the situation when something does happen. So again, initial evaluation, scene must be safe, but assume that something bad is happening. Assume it's a cardiac arrest until you know that it's not. If you're in doubt, you're unlikely to cause harm, and the benefits are going to be much greater if you do CPR. Delaying or failing to start CPR in a patient without a pulse reduces the chance of survival. Early CPR and early defibrillation save lives. I keep saying that because it's very important and very true. Compression-only CPR is a viable alternative if that's all you have, and your skills and instincts will fade without regular practice and stimulation. Sorry, that should have a T. So do something. Don't do nothing. Again, early defibrillation, early effective CPR save lives, and be prepared in case something does happen so that you can respond. So why do we talk so much about sudden cardiac death? Sorry, someone's got
come on.
Let's mute if we can. So sudden cardiac death is the leading non-traumatic cause of death in young athletes. The highest risk is in black male college basketball athletes, but really can happen to anyone. There are a number of underlying causes that we'll go through quickly. So a lot of them are cardiomyopathies. Hook'em hypertrophic cardiomyopathy is the most common, but there's arrhythmogenic dilated cardiomyopathy, and then arrhythmia syndromes, Brugada, long QT, coronary artery anomalies, and then other things like MI, dissection, commotio. All of these can lead to cardiac arrests. So your different cardiomyopathies, and hypertrophic is the most common, genetically introduced. You get myocyte hypertrophy and interstitial fibrosis. You get expansion of the ventricular septum and the wall, the left ventricle, which can then obstruct the outflow tract and lead to poor perfusion and lead to arrhythmias. You also can have arrhythmogenic cardiomyopathies, where the myocardium gets replaced with fibrofatty tissue. Again, you get to wall thinning, aneurysm formation, and then when these cardiac myocytes are not conducting electricity the way they normally are supposed to, that can lead to arrhythmias, so VTAC, VFib, which then leads to a cardiac arrest. And again, with dilated cardiomyopathy, again, not caused by ischemia or valvular disease, but the ventricle gets dilated and then doesn't conduct electricity well, and you're at risk for arrhythmias. You also have just underlying genetic arrhythmia syndrome. So Brugada and long QT are the most common. There's some characteristic EKG changes. And if you do screening EKGs, then you can pick up on these sorts of things. Most of the times you're asymptomatic until you aren't. The most common presenting symptom is a cardiac arrest or a syncopal episode. So just be aware of screening, be aware of any athletes you have that may have these underlying issues going into games. And we're going to show another case. And this is to compare and contrast the response. I'm pretty sure everyone's going to have heard of this one, have seen it. But I like to watch the video here also. Damar Hamlin, 24-year-old football player, no past medical history, and he gets struck in the chest on a tackle. So let's watch the video here. We're not going to watch through the whole thing, but I just want you to pay attention to the response times and what the people on the field are doing. So there's Damar getting hit. You don't see him collapse in this shot, although they'll show it again, but you see him stand up. So he's still got a few seconds where he's got oxygenated blood in his brain. His brain is controlling his muscles. He's moving before he collapses. Now he's down. By the time the camera cuts, this is like within seconds, under 5 seconds, you have a medical team out on the field assessing, and you can see clicking on the radio calling for EMS. They're already assessing airway circulation, recognize that he's in cardiac arrest, getting the appropriate, you have to do exposure, you have to get there, be able to do compressions. You have other people making sure that people have kind of stepped away. But there's really much more, you see much more of a response, much more organized, much more, you can tell that there's planning involved here. And that these people, and this is the commercial cut. So there were actually several minutes before this. But you already see, stretcher on the field, everyone around him.
Then he got up and just went right back down to the ground.
So you'll see again the hit here. He takes the shoulder right to the chest and he stands up, but he's wobbly, and then he collapses a couple of seconds later.
So
not what any of us want to see in there, but
So we're gonna skip through. So what went right here? So there was very early recognition. The medical team again is on the field in less than 5 seconds. There's very rapid assessment of ABCs and identification that he was in cardiac arrest. You can't treat a cardiac arrest if you don't know what's happening. And there was early CPR. It was before and on field for about 10 minutes with Rosk, within 10 minutes. There was early defibrillation. He was rapidly transported, got appropriate ICU care. The ambulance is on the field in less than 5 minutes. Again, with the prior case, CPR wasn't even started until 7 minutes. And obviously this went very, very well. He was cleared to play. He's returned to the NFL the following year. Why did this go well? And I've listened to and spoken with a little bit, people involved, and nobody takes any credit for this successful outcome. Everyone points to we were planned, we were prepared, we had an emergency action plan, and we followed it. We did everything we said we were going to do, and this was just our job. This is what we did, and they did it well, and with obviously a very, very good outcome. Let's talk a little bit about, so I don't think that anyone's ever come out and officially said that this is what happened, but it's pretty clear. So commotio cordis is a cause of a VFib arrest in a structurally normal heart. Essentially, the arrhythmia is induced by mechanical distortion of the myocardium. So most commonly with a baseball or a lacrosse ball, actually, I don't know why I have a lacrosse ball, but right here, or a hockey puck, you get hit right in the chest. And it's very rare because there's only about 1% of the cardiac cycle where you get this R on T phenomenon where basically the mechanical force creates an electrical current that's just at the wrong time to mess up your cardiac rhythm and send you into VFib. It is reversible. The only way to reverse it is defibrillation. And if you look at this clinical review, the highlighted part at the bottom, really the only thing that impacts survival is prompt CPR and prompt defibrillation. Is it preventable? People have looked at different kinds of chest protectors and equipment and things like that. And are there risk factors? There may be. So if you look at the studies for this, most of the studies involve sedating pigs and then shooting them with balls, which is a little bit horrific, but then inducing VFib and seeing, when it happens, how often it happens. And interestingly, some of the pigs, they could induce VFib almost all the time, and some of them never went into VFib. So there's probably some sort of underlying factor. We just don't know what it is. But if you see someone hit in the chest and go down, assume that this could be what's happening. And this is very, very recoverable if it's treated promptly. And then I want to go on. This is just a little bit of a side tangent on this, but there's a case I had actually in fellowship, 48-year-old male, which used to seem a little bit older, but now I'm 47 and this is frightening. Recreational triathlete, which also is me. No known medical history. This could be me, except I haven't done a half. So 2 hours after he finished, he came to the medical tent, vomiting, nausea, weak, peeled pale, and sweaty. He looked like a lot of other athletes that cross the finish line, right? We see hundreds of these. You work in an event, they come through, they all look like crap. But this was 2 hours after he finished, and he looked pretty bad. So we threw an EKG on him. And I used to assume that everyone could see this, but I showed this to an ophthalmology friend of mine, and she had no idea what she was looking at. So just to go through it. If you look at leads 2, 3, and AVF, those are profound ST elevations. There are also reciprocal changes. This is an inferior wall MI. So just something else to keep in mind, especially if you're treating, working at an event with all ages of athletes, older, I shudder to say athletes. What is that? Hold on. There we go. So acute coronary syndrome, MIs, there's increased risk of MI and death during exercise. This is even if you're in very good shape. And this man was in very good shape. He just finished a half Ironman and he looked like someone who did a half Ironman more than once. So even if you exercise, you look at this chart, more than 5 times a week, your risk of MI during exercise is more than double your baseline risk. Now, if you're one of those weekend warrior types or we all know who these people are who haven't exercised in years, but they're like, oh, I can still run a 10K. I can still run a half marathon. They go, you're actually at over 100 times the risk of an MI during exercise. So have suspicion, even in otherwise healthy adults, during and immediately after periods of exercise. And it's not always chest pain. Sometimes it's unusual shortness of breath, nausea, vomiting, abdominal back pain, shoulder pain, syncope, or people who give you that just like sense of impending doom. Something bad is happening. So just something to keep in mind. So what if they have a pulse? So airway and breathing, let's talk a little bit about that if you have issues with that. So airway breathing issues could be upper airway, mouth, throat. Was there some sort of trauma, hockey stick, lacrosse stick to the neck? Lower respiratory issues. Are they an asthmatic patient who's having an issue? Or did they get stung by a bee and now they're having an anaphylactic reaction? But what you need to know is how do I manage that airway? And I really want to boil this down to very, very simple. You need to get oxygen into the lungs. That's it. So if there's some sort of obstruction, the most common thing is the tongue and the soft tissues around the airway. So the same reason we snore, when you're unconscious, you lose muscle tone in those areas. So sometimes just a positional adjustment, head tilt, chin lift, or a jaw thrust if you're really worried about trauma, to open up that airway. And then you want to get oxygen into the lungs. So supplemental O2 is great if you have it. If not, room air is 20%, 21% oxygen. It's what we breathe all the time. It works all the time. So if you can get that oxygen into the lungs, then you're doing a good job. So using a BVM, even without oxygen, is totally fine. Obviously better if you have it, but if you don't, it's okay. Your most important airway skill is the being able to ventilate. And this is not necessarily easy. You have to have the right hand strength and you have to practice this to get a good seal so that you're actually getting air in. And there's no shame in using two people to do this. In the ER, we do this all the time. People with a lot of soft tissue in their face, difficult airways, things like that. One person can hold the mask and the other person squeeze the bag. You don't have to show off and do both at once. But this is a skill that you need to practice that can really help if someone's not breathing. There are also several airway adjuncts you may have access to or EMS may have access to. These really just help relieve the obstruction, nasal and oral airways. If someone is conscious, they're not going to tolerate an oral airway, but they might tolerate a nasal one if they have a decreased but still present level of consciousness. And then you may see things like the LMA and the common tube. Paramedics sometimes will use these. They're basically, ways not quite intubation, but to be able to get something down to secure an airway. And they work generally pretty well. Things not to do on the sideline. And I wish I didn't have to have this slide as part of my lecture, but every time I think about taking it out, then I hear another story and I'm like, oh no, we need to say this. You don't need to intubate on the sideline. Again, if you can ventilate, if you can use a BVM, if you can get oxygen into the lungs, you can do that indefinitely. You don't have to put an ET tube in. So please don't try to be prepared to do it. There's just no reason. And please, please, please don't even spend any mental energy preparing to do a crike or things with pocket knives, ballpoint pens, coffee straws. I wish I didn't have to say that, but I've heard stories and they're frightening. Please don't do it. All right, so what if they're breathing and they have a pulse? So after ABC, we get D and E, so disability. So do they have some sort of altered level of consciousness? Or is their mental status not normal? And if they are altered, then we need to figure out why. And then the E is usually exposure or environment. You really want to do a good physical exam, assess their body, assess the surroundings to see if we can determine what the cause was. Are there injuries or other factors that may have led to their collapse? And if they have a totally more normal mental status, but they're collapsed and can't move, think, neurodeficits, assume some sort of spinal injury. So let's talk a little bit about trauma to start. So head and neck injuries. So we see head injuries all the time in sports, right? We can do a year fellowship just like concussion, I'm sure. But we don't really care in this environment about concussion. And I may be sacrilegious in saying that, but concussion is more of an outpatient issue. It's not a sideline issue. If you think someone has a concussion, but they're otherwise okay, you pull them out, they're done for the day. You see them in training room, they follow up in the office or trainer or whatever. We're kind of done from that perspective. What we care about is we want the red flags of serious head injuries. You don't want to miss this. You don't want to miss this. You don't want to miss this, right? You don't want to miss the skull fracture, bleeds, spinal cord injury. That's what you really have to have high suspicion for and what you want to send for more evaluation, CAT scans, MRIs, whatever they need. So what are you worried about? Persistent altered mental status. So not just concussed, but something just isn't right. So, you have your Glasgow Coma scale, opening eyes, are they responding appropriately verbally? Are they moving appropriately? Or do they have a focal neurologic deficit? And then persistent vomiting can be a sign of increased intracranial pressure. One episode of vomiting, generally fine, but if you're vomiting, can't stop, that is very worrisome. And again, focal neurologic deficits in terms of neck injuries. So if you have bilateral symptoms, that's not a stinger. you have to be very, very concerned. You could, I guess, maybe get a bilateral stinger, but I would send that person for imaging 100% of the time. Or if they have any sort of midline spinal tenderness, again, if they no concerning features, might be fine, just concussion precautions, but be on the lookout for these sorts of things. Abdominal and pelvic injuries, very briefly, you can get significant blunt trauma, and there's a lot of stuff in the abdomen and pelvis that can get injured. You really want to focus on your vital signs here. Are they hypotensive? Or are they abnormally tachycardic? Bruising and rigid abdomen would probably develop later. Fast exams, we all love our ultrasounds, but let's remember what a fast exam is for. A fast exam was designed to see, is this patient stable enough to go to CAT scan before they go to the operating room, or do they need to go to the operating room immediately? This is not a sideline assessment tool where you look at them and you say, oh, they're fine. It might just be too early, not enough blood there, whatever. It does not rule out anything. If you see something, that could be helpful, and getting you to expedite, they're really in bad shape and they need to go soon. But don't rely on it to say that someone's okay. And then hematuria can be a sign of renal injury, hematoma, that sort of thing. If they're altered after blunt trauma, assume shock, assume badness, send them to the hospital. More reasons for collapse. All right, let's go through. Let's talk about heat and dehydration for a little bit, and then some medical issues as well. So there's a whole spectrum of exertional heat illness. Doesn't have to be exertional, but typically with athletes, that's what we're talking about. So ranging from minor disturbances in thermoregulation to exertional heat stroke with multi-organ system failure. So heat cramps, heat exhaustion, heat stroke. Heat illness, and we're getting kind of into the thick of things here. We're in August, we're in, the start of football season, two-a-days in 90+ degree heat, humid, full pads, even half pads, the highest risk, obviously with football, but other sports as well this time of year. We've really gotten a lot better at this, I will say. Some high profile deaths have led to a lot of policy changes and practice changes, working on acclimatization and making sure that people have the time to recover or are prepared for these sorts of practices, but it still has to be on your mind, especially as you're out there in August and September. So risk factors, strenuous exercise and high temperature and humidity, lack of acclimatization, obesity. So you need surface area to cool your body off. If you have a low surface area to weight ratio, you're higher risk for that heat to build up. Dehydration, not necessarily the only factor, but it definitely contributes. And then be aware of medicine supplements that your patients may be on, your athletes may be on, and then a previous history of heat illness. If it's happened before, it's much more likely to happen again. You can prevent, again, acclimatization, proper clothing, changing medications, modifying activities, allowing for prehydration, rehydration. This is preventable. Heat cramps, not necessarily, you don't have to cramp, but and it doesn't have to be related to exercise, could be just heat, but it can happen in swimmers, ice hockey players, things like that. And it affects your ability to perform. The management is really just hydration, rest. Oral fluids are fine. Physiologically, you actually can do a little bit better with oral fluids. Sometimes our athletes really want IVs. They're not necessary. I tell patients that all the time in the ER. If you can drink, that's just as good, if not better. And when we had our IV fluid shortage a couple years ago, this really became something that we tried to drill into people's heads, but we're kind of back to giving IVs, but you don't have to. Red flags for muscle cramps. So if they're persistent or systemic cramping or severe pain with no cramping, that should raise concerns that there might be something else going on. Sickle cell crisis, rhabdomyolysis, exertional hyponatremia, things like that might be beyond just your simple muscle cramps. Briefly about sickle cell trait versus exercise-associated muscle cramps. So sickle cell trait can be associated with exertional sudden death. 37 times higher in D1 athletes. This is why we screen D1 athletes or college athletes for sickle cell trait. And there's a whole medical cascade, including rhabdo, hyperkalemia, acidosis, DIC, cardiac and renal failure that can precipitate from this. So you get brief periods of intense exercise with intense pain or weakness. There's typically not the muscle spasm that you see in muscle cramps. And high flow oxygen can help treat this because it reduces sickling and hypoxia. So just keep that in mind, especially if you have athletes who are sickle cell trait positive. Heat exhaustion as we move along the spectrum. So basically your inability to maintain cardiac output due to strenuous physical exercise and environmental heat. You often collapse during exercise or immediately after. Sometimes temperature is only mildly elevated, but the most important thing is there's no CNS involvement. You're not affected with your mental status or anything else neurologic. You might be dehydrated, you might not, it's not required. The treatment here is to cool them. It's not rocket science. If someone's hot, you cool them down. Lay them down, put their feet up in the shade, take off any excess clothing. If you're monitoring rectal temp, cool them until they're about 101. Doesn't matter as much for heat exhaustion as for heat stroke. You can do, again, oral hydration is totally fine. If they're not getting better, then you can think about transporting them. But typically these people need 5 or 10 minutes and then they're up and moving and they do totally fine. Exertional heat stroke is when you have CNS dysfunction. In addition, you can also have other organ and tissue damage with high body temperatures. So core temp over 104 during activity or right after, preferably a rectal thermometer if you have it, and CNS dysfunction. So these people are not thinking clearly. They might be stumbling. They might, word finding difficulty, things like that, seizures, delirium, coma. All sorts of different CNS symptoms that you can have. Also, you can have GI symptoms. A lot of times, diarrhea, especially people who run long races, you've been shunting blood flow away from the GI tract for a while, so that's not uncommon. The management, really, again, you need to cool them. And the morbidity and mortality are related to the duration of core temperature elevation. So this is where it's important to cool them where you are. You don't want to stick them in an ambulance where they're going to sit in the back for a few minutes and then they're going to drive however long to the hospital and then they're going to sit in the ER and not be seen for an hour and that all that time their brain is cooking, their organs are cooking. You want to cool them down on site. So have a high index of suspicion, especially if they're hyperthermic and any CNS issues. So again, initial management, always every patient ABCs, but after that, vital signs, rectal temp, you can check a glucose, and if you have an ISTAT, you can check their sodium also. But you want to cool them first and transport second. Cool them down to at least 102, and then these people all need to go to the hospital. If you don't have a rectal thermometer, assume that it's heat until proven otherwise. Again, you're not going to do much harm by cooling someone who's hot. Cool them until they begin to shiver. You can treat them for 15 to 20 minutes. You cool at a rate of about 1 degree Celsius, about 2 Fahrenheit for every 5 minutes that they're in the water. So you can do that calculation and figure out how long they need to be cooled for. You can put them in a tub. You can do an ice towel rotation. Those towels do warm up pretty quickly, so you want to keep switching them out. You can hose them down. You can pack them with ice packs. Basically anything cold. Just be prepared and know what you have available either on the sideline or in the medical tent, wherever you are. Again, cold showers, shade. You can make an ice burrito. So if you don't have a tub, you fill a sheet with ice and you wrap them up. And we all know this, but this is not a fever. There's no role for NSAIDs, no role for acetaminophen. Here's a healthy volunteer showing off the ice burrito here. Again, you just cover them with ice, cover them with water, wrap them up, and let them cool off. Some misconceptions here. You don't have to stop sweating to get heat stroke. You're actually almost always sweating profusely when you collapse. You don't have to be dehydrated. Doesn't help, can make things worse, but you don't have to be dehydrated to get heat stroke. And you may initially appear lucid and then you may rapidly deteriorate. I've had this happen in several medical tent for several races where people seem okay and then all of a sudden they're just not making sense. So, have a low threshold to cool them. Shivering doesn't delay cooling. Shivering is fine. Doesn't happen that often, but don't worry about it. And they will get a little bit of peripheral vasoconstriction when you put them in the tub, but that doesn't matter. They're still going to cool off. So, again, not rocket science. If they are hot, cool them off. Very briefly about seizures. So most common cause of seizures is having an underlying seizure disorder, but it can also be caused by trauma, by hypoglycemia and other electrolyte abnormalities, toxicology, sometimes different agents can cause that, or infection. Probably not going to be an issue with your athletes, but always could be. So do's and don'ts of seizures. So the main thing is just protect them from further injury. You want to make sure that they're not going to bang into anything. Don't let them fall, ease them to the ground, patting around them if you have it. Do not stick anything in their mouth. You don't have to, worry about them swallowing their tongue. That's not a thing. Basically just make sure that they don't do more harm to themselves. You can give them benzos, usually not necessary. What I was taught in residency over and over is you find your slowest nurse, the 80-year-old who's been there for 50 years, and you tell them to go pull up the Ativan or the Valium, whatever, and they're going to take 5 to 10 minutes to shuffle off over to the Pyxis and get it. By the time they get back, you probably don't need it. Average duration of a seizure is 30 seconds to 2 minutes. When you're watching a seizure, it feels like forever. And when you talk to patients and like families who have witnessed seizures, they'll tell you that they lasted 15 minutes, 20 minutes. They didn't. Every once in a while, you get status epilepticus, but most of the time, it's going to be a couple minutes that just feel like forever. And they may desaturate because they're not going to be effectively breathing during this. But again, you can hold your breath for 30 seconds. That's okay. If you have supplemental oxygen, you can give it, but usually not necessary. If you get into prolonged seizures, you have to worry a little bit more about it. But most of the time, not going to have to worry too much about that. So diabetic and electrolyte emergencies. So with an undifferentiated ultramental status and collapse, if they're not hot, especially, you want to check their glucose and check their sodium if you're able to. If they're hypoglycemic, give them glucose. Again, not rocket science. Fix the basic things that are wrong. If you know they're diabetic, or if you can figure that out by a bracelet or a tag, that can be helpful. A lot of people now have insulin pumps. You may have to disconnect that if it's malfunctioning or if it's just otherwise causing problems. Again, most of them, they're much better these days. Most of the time, it's not going to be an issue, but it's something to have on your mind and be aware. And if you have someone who is diabetic that you know of, and they're hyperglycemic, you have to think DKA or HHNK. And the main issue there, especially with athletes, is dehydration. This is typically more the underlying cause than an insulin issue. And the treatment for that is just fluids, fluids, fluids. And if they're altered, it may need to be IV, and that's totally okay. Hyponatremia, the biggest risk factor there is rapid, significant consumption of free water. So these are people running a marathon, and every half mile they stop and they get the water, and they never get the Gatorade, and they drink, 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 drink. And all of a sudden they're altered, and their sodium is 120, 115, something like that. You want to fix this with oral salt if they have the mental status to take in oral fluids or IV fluids. And again, these people are going to go to the hospital. And then really quickly, just environmental. I have a whole section that's not in here on altitude and things like that. If you're at altitude and you have issues, bring them down. But lightning, again, the time of the year is the most prevalent now. About 400 strikes a year in the US, and about 10% of them are fatal. Golf courses and ball fields are the most common, wide open spaces where people are holding metal objects. The issue with lightning is you get a whole lot of electricity very quickly. And if it affects your heart, if the electricity gets to your heart, can cause cardiac contusions, myocardial stunning, arrhythmias, and even aortic injuries just from the force of that. You can also get arrhythmias a little bit afterwards from the catecholamine surge. You can imagine a lot happens with your body when you get struck by lightning, and that can lead to arrhythmias. So you want to be on the lookout for that. Management, again, scene safety. If there's still lightning coming down, you don't want to get struck by lightning. Lightning doesn't strike twice is not a real thing. It can strike twice, and it will. Keep yourself safe. The other thing to know is if you have a lot of people, like a big crowd that was struck by lightning, typically in a mass triage, you do triage in mass casualty, and black tags are people who basically aren't salvageable. They have no vital signs. After a lightning strike, those people are salvageable. It's a very temporary and reversible cardiac arrest. And so you can treat that and you can save people. CPR, defibrillation, all your ACLS protocols to treat those people, even though in a typical mass casualty, traumatic, like penetrating trauma, things like that, they would be the ones you just leave. Don't leave those people. All right, so in summary, ABCs always, always, always first. Check for circulation. Assume a cardiac arrest until proven otherwise. Early CPR, early defibrillation save lives. Ventilation is the most important part of airway management. You don't have to get fancy. You just need oxygen into the lungs. And plan, prepare, practice, practice, practice. The more you feel like you know what you're doing, the more comfortable you are, the more you can remember, the more you're trained, the better it's going to go when something actually happens. And again, these things don't happen often, so you lose those skills if you don't practice them. Trauma, be aware of altered mental status, neurodeficits, persistent vomiting for head injuries. Vital signs are vital, so pay attention to hypotension. Tachycardia, again, a lot of times our athletes during exercise are tachycardic, but that should get better. Have a high index of suspicion, and don't be afraid to transport. If someone's hot, you cool them down on site before you transport. And then remember your glucose, your sodium, and your other metabolic causes for collapse. Again, oh, Alan was supposed to pop up earlier for practice, 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 practice. We're talking about practice. Yes, practice. Some questions for you. So survival rates after a VFib arrest decrease approximately how much for every minute defibrillation is delayed? Question 2, what finding with a head or neck injury is most concerning for a serious injury? And question 3, primary difference between heat exhaustion and heat stroke. So question 1, that is 7 to 10%. Remember that survival curve drops off very quickly, early defibrillation. Findings that would be most concerning would be bilateral hand tingling. Again, bilateral symptoms with a neck injury are very concerning for a cord issue. And the primary difference in heat exhaustion and heat stroke is altered mental status. Some references there, and then I will happy to take any questions.
Awesome. Thank you so much, Dr. Oshlag. This is such a high yield topic. As far as from somebody that just recently took the sports boards, this is care of emergency conditions is 20% of our of the sports board material. So this is a very high yield lecture. Couple comments I'll read off from the chat so far, and then it looks like we have a couple questions. So one comment is saying ECAST, which stands for exercise collapse associated with sickle cell trait, is also part of the sickle cell cause of collapsed athlete. Don't forget that cramps with soft muscles aren't from heat. Sickle cell crisis can also cause painful cramps. So some good reminders there. Another comment with cooling, make sure you are agitating and circulating the water and ice with hands in a tub, rolling back and forth in a burrito. You get better cooling by circulating the warm water away from the skin and keeping the cold water against them. That was similar to your comment about like having to rotate those rags because whatever's touching the skin warms up pretty quickly. One question we have here from Katie Kiley from Long Beach Memorial. She said, I missed what the average temperature decrease per minute was, if you don't mind. If you don't have a thermometer while cooling, what's the average temperature decrease per minute?
So for every 5 minutes, it's 1 degree Celsius. So about 0.2 per minute. And then converting to Fahrenheit, essentially you can double it. So about 2 degrees every 5 minutes.
Awesome. Another question here. Can you touch on hypertonic saline administration?
Not something I would ever do on the sideline. We use it rarely in the hospital if you're really hyponatremic. It's not something that I would have with me, I think, is the main thing. Like I wouldn't have it in my medical bag available to me. In the ER, if you know someone has rapidly become hyponatremic and you want to correct them rapidly, or if they're seizing, then you can give it and give a small bolus. But I think in this environment, it's not something that when you start to prepare for things like that, I get a little concerned that we're going to try to treat more than we're really capable of treating in the field. And these people really need to get to the hospital.
One follow-up question, can you comment on, like, let's say you're at the marathon where there is a decent amount of resources, would you administer it then if you have the results that are in front of you to treat?
I could come up with a scenario where you would use it, I guess. Yeah, if you're talking about, New York, Boston, Chicago, places with these gigantic finish line medical tents that are basically mini hospitals, and you have reliable testing and reliable access to like IV access and all the supplies you could want. But keep in mind, these people are still going to go to the hospital, and you really want to transport them sooner rather than later. So, setting up the time to run hypertonic saline. And then I don't know that I would want it running while the patient's in an ambulance. So, I'd still be a little bit hesitant to do it, but I wouldn't say complete like 100% no. I could come up with situations where you might do it.
Got it. And then one other question. This is actually a question I have, which is, I guess, might kind of cross over into what we're already talking about a little bit, and I'm thinking like, again, like something like a big marathon where you have some resources, but let's say you have somebody that is in severely hyperthermic, needs cooling, but they're so altered that they're not protecting their airway anymore. How do you approach how to intubate them? Do you intubate them before they're in? Do you bag them while they're in the ice bath? I know it's a very specific question, but I'm always curious on people's take on it.
I mean, I guess it depends on how compromised their airway is. I think I would try like some sort of airway adjunct and supplemental oxygen while they're in a cooling tub. I guess you could ice burrito them and intubate them at the same time. This is one of those things on the test question. You have to pick something to do first, but in reality, you do it all at the same time. Um, you know, breathing is more important than temperature, but temperature is also very important. So, if you have a pulse ox and they're hypoxic and desatting and not breathing, then you have to address that first. Um, but that, I think would be a rare situation in which they're not breathing at all. And if it's just that they're not doing the best job of protecting their airway, maybe they have some like sonorous breath sounds, like can you put in a nasal airway adjunct, or throw a nasal cannula on and get their oxygen level high enough that you can then cool them off. And then as they cool, their mental status is going to get better. And these people do improve dramatically once they start to cool off, and then they're going to be breathing fine. So, hopefully, ultimately, you won't need to intubate them, and you can manage their airway externally.
Awesome. I think this lecture and this discussion is a good reminder of, um, even though there's a lot of problems we could identify on the sideline, and we might know how to treat them, and it's not necessarily our job in that moment to fix it 100%. It's important to identify what they need and get them to where they need to be to get the proper treatment. And I think that was something I learned a lot of this past year during fellowship. So. Let me scroll and see if we have any other questions. I'll give it another couple seconds. If anybody wants to put another question in the chat, or feel free to unmute yourself as well. We have a couple more minutes, but if not, we will thank Dr. Oshlag for being with us this past hour. And we look forward to hearing you talk hopefully in the future. So
Yeah,
thank
thanks for having me.